So the first part is basically I'm going to be covering multiple sclerosis, Parkinson's disease, and epilepsy. So multiple sclerosis. So I'm trying to get rid of the bar at the top. Doesn't matter. So multiple sclerosis. So definition for multiple sclerosis. It's a inflammatory disease. So it's a neuroinflammatory disease, and it involves demyelination across multiple sites in the central nervous system. And lesions are disseminated in time and space. So that's the definition for multiple sclerosis. Epidemiology-wise, mean age, usually it comes on around 30, age of 30, so young adults. More common in females, and mainly affects like white, Caucasian, Scandinavian community. And 15% of MS patients are confined to a wheelchair within 10 years of diagnosis. So the key bits out of that is that it's a neuroinflammatory disease involving demyelination across multiple sites in the central nervous system, and it's disseminated in time and space. That's the main bit. So again, there are some environmental things people think maybe contributing to multiple sclerosis. So viruses, the latitude where you're from, your diet, vitamin D levels. But the key terms, some key terms you might hear when you're reading a multiple sclerosis is you might hear clinically isolated syndrome and radiologically isolated syndrome. So clinically isolated syndrome is you might have symptomatic MS with a radiological lesion, but which isn't explained by any other causes such as infection or fever. But again, that's a single episode, and it's not disseminated in time or space. And then radiologically isolated syndrome is you might see a lesion on a scan, but causing no symptoms. So again, like I say, going back to disseminating time and space, this comes from the McDonald's criteria, which is used to diagnose multiple sclerosis. Another thing you might find in multiple sclerosis is when you do a lumbar puncture, you'll see oligoclonal bands, and if there are oligoclonal bands in a lumbar puncture, this is evidence of dissemination in time, because the oligoclonal bands are caused by the breakdown of the myelin, and therefore that can be evidence of dissemination in time. So you've got clinically isolated syndrome and radiologically isolated syndrome, and then you have MS. And for diagnosis of MS, it needs to be disseminated in time and space. And if you do have the oligoclonal bands on CSF, then that could be evidence for disseminated in time. So if you look at MS, there are different types of MS, courses of MS. So the first one you see, probably most common one, is the relapsing remitting MS. And this is when you get a relapse, and then you get some full recovery or some recovery, you get no symptoms, and then you get another relapse. Another one is primary progressive MS. So primary progressive MS, you get symptoms, and then you might have a period of time with no symptoms, but you don't get any resolution of symptoms. And then you get symptoms again of MS. So the difference between the relapse and remitting is you do get your symptoms improve, they get better, either they completely go away or partially go away. Whereas in primary progressives, the symptoms remain and they don't go away in between a relapse. And then you can have the secondary progressive MS, which starts off as relapse and remitting MS, and then it becomes progressive MS. And then you can have progressive relapsing MS. Again, it's not as common, that one. So relapsing remitting MS is the most common one. Relapses last usually at least 24 hours, and they differ in severity. And again, steroids are used in treatment of relapses to speed up the recovery from relapse. Patients usually get average of 1 or 2 relapses a year, and recovering between. Initially, you would get full recovery, but then later on in the condition, you might get partial recovery. Secondary progressives are developed after relapse and remitting. The disabilities start to accumulate more rapidly, and remission from relapse and remitting, the remission phase is lost. Again, this happens at different rates of progression for different people. primary progressive, no remission, can get periods of more stable disease. That's the less common one. And progressive relapsing MS. So again, that's a bit of an overlap between primary progressive and relapse and remitting. A very minority of MS patients presenting this way. It's hard to tell the difference between this one and a primary progressive MS until they have their first relapse. So we've mentioned this relapse. So what is the definition of a relapse? So there's a strict criteria in order to diagnose a relapse. So usually a relapse arises over hours to days and worsens over several weeks, and then gradually subsides over several weeks or months. It has to be, a relapse has to be over 30 days apart to be classified as a new relapse. And yeah, so that's a definition of the relapse. So it arises over hours to days, and in order for it to diagnose a new one, it has to be 30 days apart. So most patients, like with MS, will present with optic neuritis as the first symptom of MS. So what is optic neuritis? So optic neuritis, the way it presents is you get periorbital pain, which is worse on eye movement. They get reduced visual acuity and blurred vision, and they have loss of color vision. So usually it's the red color that they lose. It's you have a positive relative afferent pupillary defect, which I'll be covering on the next slide. Again, it's usually one eye, unilateral, and symptoms peak at about 2 weeks, but then resolve by weeks 4 to 6. So a quarter of MS patients present with optic neuritis, and 70% of MS patients get optic neuritis at some point in their disease course. So relative afferent pupillary defect. So this is an example of a relative afferent pupillary defect. This is RAPD in the left eye. So when the light is shone in the right eye, you get pupillary constriction in both eyes, whereas when it's shown in the left eye, you will not get constriction, and that's because you've got inflammation of optic nerve, which is the afferent nerve when you do the pupil reflex. So that's an example of a left-sided RAPD, and it's the swinging light test for RAPD. Another eye condition that you might get with MS, you might see, is what we call intranuclear ophthalmoplegia. So intranuclear ophthalmoplegia happens when there's a lesion in the medial longitudinal fasciculus. So the medial longitudinal fasciculus is a connection between the abducens nerve and oculomotor nerve. So abducens nerve, if you remember, innervates, if you came to my cranial nerve teaching, it innervates lateral rectus, and it causes the eye to abduct. And then oculomotor nerve supplies the medial rectus, causes it to adduct. Now, obviously, when we abduct one eye, the other eye adducts, and vice versa. So they have to have some sort of connection in between them, where to make the two muscles work together. And this is what we call the medial longitudinal fasciculus. Now, if you get a lesion in that, then, like in this example, there's a lesion in the right MLF. So what you get is you can't adduct the eye, and the ipsilateral eye will get nystagmus. So the eye that's getting abducted will present as nystagmus, and this ipsilateral eye will not be able to be adducted. So that's an example of a right MLF lesion, and that's what we call intranuclear ophthalmoplegia. So the optic neuritis is the most common one, but patients can also get intranuclear ophthalmoplegia and MS. So like I say, early symptoms of MS will be optic neuritis. They can get altered sensations, so paresthesia, burning sensation, numbness, and also trigeminal neuralgia. Again, they can present with fatigue, and it's important with these symptoms that you rule out other conditions that can mimic MS, such as underactive thyroid, anemia, and we'll cover some of the other MS mimics later on. And again, it's slower processing. So again, depending on where this lesion is, the demyelination will present with different things. So usually cerebral hemisphere will cause things like paresthesia, paralysis. Spinal cord lesions can cause spasticity, sexual dysfunction, sphincter dysfunction of the bladder and bowel. Optic nerves can cause optic neuritis. Again, if you had a medulla or a pontine lesion, you can get dysarthria, double vision, vertigo, nystagmus. And again, cerebellar signs as well, if you had a cerebellar lesion, because this is all part of the central nervous system. If you remember the mnemonic Danish for cerebellar condition, so dysarthria, ataxia, nystagmus, intention tremor, slurring of speech, hypotonia. So that they're all presentation of cerebellar problems. And again, because it's central nervous system, usually it's upper motor neuron signs. So spasticity, brisk reflexes, weakness, and then autonomic dysfunction as well. And then this thing we call Uthoff's phenomenon. So again, don't confuse this with a relapse. So Uthoff's phenomenon is simply when they come out a hot shower or a hot country, or when they've been doing activity, they'll get an exacerbation of their symptoms of MS, especially visual symptoms. And that's what we call Uthoff's phenomenon. That is not a relapse, because you've got to remember the definition of relapse from earlier. And then another sign we might get Lermit's sign. Now that one is when they bend their neck, they get this electric shock sensation down their spine. It's a type of neuropathic pain, and this can occur in other things as well as MS. So normally the investigation, so we could do MRI to look at these lesions, so T2-weighted MRI. If you want to identify a new lesion from an old lesion, then in the MRI scan you can add gadolinium, and gadolinium will show up newer lesions. I'm not got much experience in radiology, so I can't answer any questions other than that. But yeah, so you can add in gadolinium to look for new lesions. You can do visual evoked potentials, and again, like I say, a lumbar puncture to show oligoclonal bands, which can show dissemination in time. And there you go, that's an example of MRI. So classic MRI findings that we get in MS is we get juxtacortical lesions, periventricular lesions, which is also known as Dawson's fingers, infratentorial lesions, and spinal cord lesions. So these are classic areas of lesions you get in MS. So pathology. Lesions, white matter lesion, juxtacortical, infratentorial, and the optic nerve as well. So the management of MS. So usually it's a multidisciplinary team approach when you're managing MS, and it involves obviously multiple MS consultants and specialist nurses, physiotherapists, OT, charities such as MS Society, speech and language therapy, social services, and then symptomatic management. Again, relapse, usually you can give them steroids, relapse, and then there's some disease modifying agents that I've listed there. And then there's new novel therapies, which was made in my hometown, Sheffield, the bone marrow transplant. So it's always worth looking into if you're interested. And then symptomatic management as well, like I mentioned, so laxatives for constipation, urinary retention, you can give oxybutynin or intermittent self-catheterization. Muscle spasms can be treated with physio, Botox injections, baclofen pumps, gabapentin, diazepam. And then there's also scope for cannabis, which is an interesting area to look into if you're interested, for spasticity. And again, some of the poor prognostic factors for MS would be male gender, late age onset, motor, cerebellar, or symptom involvement early on in the disease. And then, like I say, some of the MS mimics. So one of them is neuromyelitis optica. So now that is antibodies against the myelin protein, anti-aquaporin 4 and anti-MOG. Again, in this one, in neuromyelitis optica, it's usually bilateral optic neuritis, whereas in MS you get unilateral. Spastic weakness in lower limb, sensory problems, bowel bladder. So you get spinal cord lesions and you get optic nerve lesions. So transverse myelitis over 3 or more vertebral segments. Other things you want to like SLE, so lupus, sarcoid, acute disseminated encephalomyelitis, and again vitamin B12 deficiency. So anyone presents with neurological symptoms, weakness, paresthesia, then it's always sensible to just check their B12 levels. before referring to a neurologist. Yep, so that's MS. The next we'll cover Parkinson's disease. So again, the definition for Parkinson's disease is it's a neurodegenerative condition this time. MS is a neuroinflammatory condition. Parkinson's disease is a neurodegenerative condition of the basal ganglia. And the way it presents, it affects initiation and execution of voluntary movements. So the symptoms, the four classic symptoms I remember is TRAP, so tremors, rigidity, akinesia or bradykinesia, and postural instability. So TRAP. So tremors. So there's different, just going over tremors separate to Parkinson's disease. So there's essential tremors. And essential tremors is when you get tremors when you're holding things, trying to hold a position, or when you're trying to do something with your hands, you get a tremor. Now that's an essential tremor. And then there's also an intention tremor. An intention tremor is when you get overshooting or undershooting when you go into reach for things. And this is a problem with cerebellum. So if you remember the I in Danish, the intention tremor. And then the tremor you get in Parkinson's disease is what we call a resting pill rolling tremor. And this occurs at rest, where when they're not doing anything, they just start at rest, they'll start getting this pill rolling tremor. So it's different to the essential tremor and intention tremor. Now looking over rigidity versus spasticity. So rigidity is resistance to passive joint movements. So again, in Parkinson's disease, you get lead pipe rigidity. So that's sustained resistance to passive movements throughout the whole range of motion. And you don't get fluctuation. It's a lead pipe rigidity, so it's throughout the whole passive movement. And then cogwheel rigidity is jerky resistance to passive movement. So that's when your muscle tenses and relaxes, and you get this cogwheeling effect in rigidity. So the two types is lead pipe rigidity, where it's the sustained resistance throughout the passive movement, and cogwheel rigidity is where you get jerky resistance. Now spasticity is slightly different. So spasticity is something you might get someone who's after they've had a stroke, and that's what we call a clasp knife spasticity. So initially there's a lot of resistance, and then suddenly you get a loss of resistance, like when you're opening and closing a clasp knife. So it's velocity dependent. It can affect either agonist or antagonistic muscles, and there's no tremor. And it's usually you get hyperreflexia, positive clonus, which is again upper motor neuron lesion, and you can get that in stroke patients. Now, final one is the difference between bradykinesia, dyskinesia, and hypokinesia. So bradykinesia is slowness of initiation of voluntary movements, with a progressive reduction in speed. Example, when you're repeating an action like tapping your finger or thumb, they eventually get slowness. And this is what we get in Parkinson's disease. Akinesia is loss of voluntary movement. And then hypokinesia is movements of reducing scale, such as micrographia, hypophonia. And again, that can also happen in Parkinson's disease. And then dyskinesia, separate to that, is a diminished ability for voluntary movements, as well as presence of involuntary movements. So they get loss of voluntary movements, but on top of that, they get the involuntary movements. And this can happen in Parkinson's disease as a side effect of the dopamine medication. So that's the difference. So this is a classical Parkinson's disease. Again, mask-like, blank expression, stooped posture, the pill rolling tremor, cogwheel rigidity, the slow shuffling gait, bradykinesia, depression. So these are classic symptoms of Parkinson's disease. And then there are also non-motor symptoms of Parkinson's disease. And this could be things like anosmia, REM sleep, so rapid eye movement sleep behavior disorders, which presents acting out their dreams, visual hallucinations. And again, visual hallucinations can be symptom of Parkinson's disease. It can also be a side effect of the medication. Depression, and then autonomic dysfunction. such as orthostatic hypotension, constipation, urinary symptoms, erectile dysfunction, hypersalivation, and dystonia. So the pathology in Parkinson's disease, so you get the loss of dopaminergic neurons in the substantia nigra pars compacta. The surviving nigral neurons contain what we call a Lewy body, so it's a cytoplasmic inclusion, contain Lewy body. And the main component of the Lewy body is what we call alpha-synuclein. So an abnormally folded protein called alpha-synuclein, which is found in the Lewy body, and that's what we get in Parkinson's disease. And you also get loss of noradrenaline, which is producing what we call the locus coeruleus of the pons. And there's a picture there to show you where the locus coeruleus is. So loss of dopaminergic neurons in the substantia nigra, loss of noradrenaline production in locus coeruleus, and the Lewy bodies. And the Lewy bodies are things contain alpha-synuclein. And there you go. That's Parkinson's, substantia nigra in Parkinson's disease. So just going over the direct, and indirect pathway of basal ganglia, just to recap, probably not as relevant in clinical exams, but it's always good. I like to always refer back to physiology and in my talks, and just try and recap back to like first, second year when we did the science side of medicine. So the direct pathway is a excitatory pathway to the cortex, whereas the indirect pathway is the inhibitory pathway to the cortex. Now the direct pathway, again, the cortex excite, if we look at the direct pathway on its own, the cortex excites the striatum. Because the striatum is excited, it has an inhibitory effect on the globus pallidus. So it inhibits the globus pallidus. Now, because the globus pallidus is now inhibited, it can no longer go and inhibit the thalamus. Between the globus pallidus interna and thalamus, it's an inhibitory pathway. Now, because the globus pallidus interna can no longer inhibit the thalamus is able to go and excite the cortex, because again, it's an excitatory pathway. And that's how the direct pathway excites the cortex. Looking at the indirect pathway now, the cortex excites the striatum. The striatum is excited. It wants to go and inhibit the globus pallidus externa. So it goes and inhibits the globus pallidus externa. Now the globus pallidus externa is inhibited. Now it wants to inhibit the subthalamus, but because it's inhibited, it can no longer inhibit the subthalamus. So the subthalamus then wants to excite the globus pallidus interna. And because the globus pallidus externa has not inhibited subthalamus, the subthalamus can then go and excite the globus pallidus interna. Now the globus pallidus interna this time is excited, and therefore it wants to go and inhibit the thalamus. So this time it can go and inhibit the thalamus. Now the thalamus is inhibited, so now because it's inhibited, it can no longer excite the cortex. And that's how the indirect pathway inhibits the cortex. Now, when we want to initiate movement, we've got this dopamine. Now, the dopamine, the way it works is it works on the direct pathway where it excites the striatum's already excited. It will go and excite the striatum again, and therefore there's no further changes to the direct pathway. So arrow up. Whereas the indirect pathway, it actually inhibits the pathway between the striatum and the globus pallidus externa. So now, because that pathway was originally inhibitory and it went and inhibited the globus pallidus externa, now because of the dopamine, that pathway is now inhibited, and the striatum can no longer inhibit the globus pallidus externa. So therefore now, because that pathway is inhibited, the globus pallidus externa can no longer inhibit the subthalamus. So the subthalamus, let me get that right again, sorry. So that pathway comes down, and therefore, because that no longer is inhibited, that can go and inhibit the subthalamus. Subthalamus inhibited, so the subthalamus can no longer inhibit the globus pallidus interna. globus pallidus interna is excitatory. So because that's now inhibited, the globus pallidus interna can no longer inhibit the thalamus. And because the globus pallidus interna can no longer inhibit the thalamus can then go and excite the cortex. And therefore, it becomes an excitatory. So therefore, when you want to initiate a movement, you get this double whammy from the direct and indirect pathway, fix of dopamine, and therefore you can go and initiate a movement. So I know there's a lot to take in there, but I can always, if there's any questions, I can always cover that again. So just the risk factors for Parkinson's disease are age, family history, racial origin. And there's a table of all the risk factors. So age, gender being male, white, Caucasian, family history of Parkinson's disease. And again, if Parkinson's disease before the age of 50, you'd be thinking, is there a genetic component? Head injuries. So again, there are some conditions that we call Parkinson's Plus, and these are other conditions that can cause Parkinson's symptoms, and that's like Wilson's disease, drugs such as antipsychotics and metoclopramide, stroke in the basal ganglia, multisystem atrophy, and progressive supranuclear palsy. 5 to 10% of Parkinson's disease is familial. So again, like I say, if there's a family history of Parkinson's disease or it happens before the age of 50, you'd be thinking there's a familial component. These are things we had to go into detail as part of my neurology course, but obviously I'm just covering it just for a bit of interest. So you can get autosomal dominant Parkinson's disease or recessive, depending on which gene has the mutation. SNCA gene, the LRK2 gene, again causes dominant inherited Parkinson's disease, whereas the Parkin gene, pink one, they're all recessive Parkinson's disease. So investigations, there's no single diagnostic test for Parkinson's disease. There's a clinical diagnosis. You want to do blood tests to rule out other causes of tremors and things, so like thyroid function test. MRI and CT to rule out other structural causes of Parkinson's symptoms. And then you can do what we call a DAT imaging, which demonstrates the loss of dopamine neurons in the subflex nigra. Treatment. So treatment normally involves replacing striatal dopamine, enhance transmission of dopaminergic neurons, and stimulate the dopamine receptor. So there's classic treatments. So treatments, again, the treatment you might see is levodopa plus carbidopa. So carbidopa is a dopa decarboxylase inhibitor. That's the most common treatment used. You might have also heard it called Madapar. So that's levodopa and carbidopa. You can use dopamine agonists, but you want to, these can be used for younger patients because you want to delay starting levodopa because with levodopa you get reduced efficacy over time. So if it's a younger patient with Parkinson's disease, you want to try and use something else instead of levodopa. And these things can be dopamine agonists. However, there are some side effects with dopamine agonists, and they can cause cardiac and pulmonary fibrosis. You can get increased risk of impulse control disorder, especially patients who've had a history of impulse disorders or alcohol abuse. It can present with visual hallucinations and again, daytime sleepiness. And again, with levodopa, you should not, if someone's on it, you should not stop it abruptly because there is a risk of what we call neuroleptic malignant syndrome if it is stopped abruptly. They can have a dopamine agonist patch if they can't take the levodopa orally. And some of the side effects of levodopa include nausea, diarrhea, they can get GI upsets, arrhythmia. That's the problems with levodopa is what we call peak dose dyskinesia. So this is at peak dose, they can get these involuntary withering movements called what we call aphatosis. And then later on, when they've been taking levodopa for like 2 years, they can get what we call on-off effect, where the symptoms of Parkinson's disease can come back towards the end of the dose. So again, that's why you want to reserve levodopa for later on in the disease, and you want to try and use things like dopamine agonists early on in the disease. These are the aphatosis movements you can get. And then there are other adjuncts as well that can be used. And this is the monoamine oxidase B inhibitor. This can be used to reduce the dose of levodopa side effects if it's causing problems. And again, this increases the long-term effectiveness of levodopa, COMT inhibitors, and amantadine. And then symptomatic treatment. Again, you want to daytime sleepiness with, like I say, side effects. Orthostatic hypertension. Again, with Parkinson's disease, you can treat with midodrine. And again, excessive salivation that you get in Parkinson's disease, you can treat with glycopyrronium bromide. Back in a second. Yep. Sorry about that. And then the final bit that I'd like to cover is seizures and epilepsy. So what's the difference between a faint and a fit? Might be something you might be tested on in an OSCE. Or again, if you have an A&E job or something, then patient presents, they might say, I've had a fit. So you want to try and work out whether it was a genuine seizure or whether it was just a faint or syncope. So again, things that might suggest syncope would be if there was a triggering factor, so a sight of blood or anything, if there was a distinct prodrome, so they felt a bit nausea, vomiting, dizzy before the event. Again, if they were conscious, if there was loss of consciousness, so if there was a can suggest seizure versus fit, a shorter duration, quicker recovery, and then ongoing lethargy but no confusion, that could suggest syncope. So, and then a seizure could be recurrent. They might have some aura beforehand, so visual aura, auditory, they might have particular smell, automatism, convulsions at the onset to the loss of consciousness, whereas the other one is convulsion after the loss of consciousness. Longer duration, and then post-ictally, they'll be very tired and confused, tongue biting, incontinence. So there's some of the difference between a syncope and a seizure. So again, the syncope is a transient loss of consciousness, and then this is due to global cerebral hypoperfusion. So they get reduced blood supply to the head. Usually lasts a couple of minutes, and it's usually a warning sign before, like patient goes pale, sweaty, the legs go wobbly. They can get a few jerky movements when it does happen, but there's rapid recovery, no post-ictal confusion. So the most common one is reflex syncope. That can be vasovagal. So this can happen when patient sees a sight of blood, they'll get a sudden drop in blood pressure and heart rate. Situational, so after a coughing fit or after going for a wee. And then again, putting pressure on the carotid sinus can cause a syncope. And then you want to rule out cardiac causes as well. So always remember to get an ECG, because it could be heart blocks, bradycardias, tachycardias, and structural problems like aortic stenosis can cause syncope. So yeah. Orthostatic hypotension can cause syncope. So this could be also things like autonomic failure from Parkinson's disease, diabetic neuropathy. After volume loss, they might get orthostatic hypertension after diarrhea, hemorrhage. Drugs like diuretics and vasodilators can cause orthostatic hypotension. Treatment, like I say, it could be midodrine or fludrocortisone. Investigation, again, lying standing blood pressure, and again doing ECG, look at the medications they're on. Some of their medications might prolong QT, so you want to look at the QT. And then again, seizure lasts longer than syncope. Patients can become cyanosed. There might be some aura such as deja vu, tongue biting, urinary incontinence. Again, post-ictally, they'll feel tired and confused. Investigations for a seizure would be an EEG and an MRI. And epilepsy is when they have 2 or more unprovoked seizures. So the causes of epilepsy or seizures would be, it could be have a vascular cause. So I always like to look at the surgical sieve. So vascular, so it could be an aortovenous malformation, intracranial bleeds, infections such as meningitis, encephalitis, or abscesses can cause seizures, trauma, autoimmune, so autoimmune encephalitis, metabolic, so hypoglycemia or other electro abnormalities, low sodium, neoplastic, so tumors, drugs, so alcohol withdrawal or illicit drugs, and functional as well, so non-epileptic attack disorders. The things that people with epilepsy, things can lower their seizure threshold, and this could be alcohol, illness, sleep deprivation, flashing lights. These are all things that can lower the seizure threshold. So the classification, so International League of Epilepsy, ILAE classification of seizures. So you can have either partial or generalized, or another word for partial is focal. Be a simple focal or complex. Complex is when they have loss of consciousness, and then you can have a secondary generalized. So the simple partial can just present with somatosensory symptoms, motor symptoms, autonomic symptoms, or psychic symptoms. So focal or simple seizure, you have no loss of awareness, and complex is loss of awareness. So aura, so subjective sensation of simple focal seizure. So an aura is a subjective sensation, and they have complete full awareness. They can have motor symptoms, so an isolated limb jerking movement, which we call a Jacksonian march, head turning, and then sensory things such as déjà vu, jamais vu, visual, auditory, olfactory, epigastric aura, and then complex ones when they have loss of awareness. They can present with automatism, which is a non-purposeful stereotyped repetitive movement. And these can happen in things like temporal lobe seizures, where they get chewing, lip smacking, swallowing, and then frontal lobe seizures can be more complex limb movements. Generalized, so it can be secondary generalized, usually after a focal seizure. They can have absent seizures, so usually it's just school child goes pale and just stares. Can later on present with tonic-clonic seizure later on life. A tonic-clonic seizure, atonic, myoclonic, but these words are going out of fashion nowadays. You just call it a generalized seizure. So investigations for seizure like MRI, EEG, and also do bloods. So management, usually long-term management, could be carbamazepine for focal seizures, or levetiracetam, or also known as Keppra for generalized seizures. In terms of driving, if they've had a seizure, they can't drive for 6 months after a single seizure. Has to be seizure-free for 12 months if they've got a diagnosed epilepsy, so 2 or more seizures. And again, they can't drive for 6 months if any of their medications have been changed. So you might come across status epilepticus in your practice. So status epilepticus or seizures can happen if their levels of the anti-epileptic medication isn't quite right in the lower levels. If they've had a brain injury or congenital malformation in the brain, cardiovascular accident, hypoxia, drugs or alcohol withdrawal, brain infections, or metabolic problems. So initially, when you see someone have a seizure, the main priority, ABCD, airway protection, put an airway adjunct in, whether it's a nasal, pharyngeal, or oropharyngeal airway, and then treat the hypoxia, so 15 litres of oxygen, and then protect their surroundings, make sure they're not going to get hurt from things around them when they're having their seizure. And this is why it's safe to put them in a recovery position. So recovery position, move any furniture, nothing, make sure that there's nothing they can aspirate on in their mouth, oxygen, and then keep them safe, don't panic. As long as you've done these things, obtain intravenous access, so a large bore cannula in the ACF, take some bloods, VBG, check the blood sugar levels, most important thing. And again, long-term, patients can get cardiorespiratory collapse, electrolyte imbalances from seizures. They can get rhabdomyolysis from muscle breakdown, leading to AKIs, hypothermia, organ failure, and again, cerebral edema. So these are the sort of things you're thinking later on after they've had their seizure. So treat the seizure, benzodiazepines, consider other possibilities. Is this a non-epileptic attack, functional cause of seizure? Could it be pregnancy? Could they have eclampsia? emergency antiepileptic drugs such as benzos. Investigation, so your bloods, your VBG, ABG. Think about hypoglycemia as a cause. Again, Pabrinex if you're thinking of alcohol withdrawal or low nutrition. And then if the seizure is not resolving, then think, is there another cause for this seizure? So we're not treating the cause here. Is there something else keep maintaining that seizure? Is it a cancer in their brain that's causing this seizure? In which case you might want to give them something like mannitol, which will reduce the cerebral edema. And then again, the most important part in seizure is the airway, breathing, and cardiovascular instability. So make sure you're giving them fluids, fluid resuscitation. And then if it's in refractory status, then as soon as someone has a seizure, you'd want to put the crash call in, get an anaesthetist there, and whether they will think about whether they want to anesthetize that patient who's having a seizure to control their seizure. So the reason you can't keep giving benzodiazepines when someone's having a seizure is because benzodiazepine is a GABA agonist. Now, what happens is we got these GABA receptors, and therefore we're giving patients benzodiazepine when they're having a seizure to try and GABA is the inhibitory, glutamate is the excitatory. You want to try and increase the inhibitory pathway by giving a GABA agonist. But as the seizure goes on and on, your neurons internalize these GABA receptors, and therefore GABA stops working, and therefore let's switch my phone off. Sorry. So yeah, the GABA receptors stop working because obviously they've been internalized. You've only got glutamate, so giving further benzodiazepine doesn't work, and therefore you want to be thinking of anesthetizing the patient or other drugs. And that's status and epilepsies in a nutshell.